Good morning, everyone. Thank you for joining me today in my webinar talking about using CGM data to optimize diabetes care. Actually, we have many goals to be covered, but we try to cover the first two today and later on we can continue. Our goals is to discuss continuous glucose monitoring, standardizations of the CGM data presentations, and the ambulatory glucose profile, interpretations of the AGB reports, Libre professional logging, and case scenarios. We will start our first part, continuous glucose monitoring, talking about diabetes control, glucose monitoring, CGM versus self-glucose monitoring, mechanism of actions, advantage, parts, types, and accuracy and reports. Actually, I love to start my lectures every time talking about the challenge of diabetes self-management, taking this photo from Dr. Amy when she presented in the ASD, and she's talking about the diabetes management. It is lifetimes, 24/7 commitment for people with diabetes. Diabetes self-management is around the clock. So even if you have a facilities of pump, of monitor like that, every time they need to plan, to think ahead, planning food, counting carbs, what about hypo, receiving data in their, either in their machines, regular machines, or new updating when they need to worry about hypoglycemia, whatever they give a dose, they need to adjust this insulin dose, calculating how much they need it, and they need to change the dose, whatever they are competing stress, thinking ahead if they are going to do exercise, going outside, going to the party. So they need to balance all the parameters in daily life issue to have at the end safe lives. So this is a very difficult challenge. They need to do it well, probably to have good controls. So we as a healthcare professionals, we need to help them, to aid them during this journey. Not only tell them about how much insulin they will take, but also they need to educate and support them, telling them about how it will be the best management they can receive it, either MDI therapy, or if there is a facilities of the pump, you need to do it by teamwork. You need to involve the clinical dietitians to take them about the balancing food and activity and how to do carbs countings, and you need to teach him about the blood glucose monitorings, how to manage new technologies they have it, and overall you need to take care of their psychological and psychosocial issue, because this is a base for every management. Overall, to take them all these parameters, they needed to complete the good control. For the good control, not only A1C, but you need to invest the new parameter for control, which is time in range. All of these should be end in a good health versus complications. This is your aim, this is your goal as a healthcare professional. Okay, I will cover in this webinar few about blood glucose monitoring and the new technology of managing diabetes like CGM, and of course the new era of time in range, which was the best management for the outcome of diabetes nowadays, which you should install it to your patients. So talking about the old home glucose monitorings and meters, and we are talking about previously it was being invented at 1970. These are the first machines which they use it to measure the blood glucose, and here is a new one. It's not new one, but here is the home glucose monitoring machine, which was being exerted in the pharmacy or the market, as we said. To some extent, you have Freestyle, Libre, EquiCheck, One Touch. So you see, this is the most famous one. To some extent, it looks similar to each other in the accuracy. The difference will be in the needle size, in the screen, and how they can store the information. They have it for how many data can be exerted there. But to some extent, it looks like each other, and still the patients use it. It necessitates, of course, finger prick. You need to prick yourself to have the readings. And transferring to the new machines, current glucose monitoring system, CGM machine, we have famous for one nowadays, starting with Abbott Freestyle Libre. sensors, which is more available in our hospitals. And also there is Dexcom, either 5 or 6G, which is the second one available. And we have Medtronic Guardian Collect heart studies inlet. Of course, Medtronic is a pioneer in diabetes with a lot of invitations in the bumper. So we have again sensor for it, and sensoric evidence, and is still not reaching our surfaces. But as you see, the sensors will be exerted under the skin, and then you can transmit the readings. But it is the most accurate one. But you have something inserted under your skin, you feel a little bit shaky, I think, to insert it, but it is very promising one. Okay, I forgot to tell you, whatever I present slides, I may put down it the reference which I use it, like monitoring diabetes type 1. If you want to go to more details, you will just reach this web for more information. And this is how it can act. How to optimize the glucose, blood glucose. All of us know the blood glucose is the best one if you have if you prick yourself, because it will give you directly blood from the capillary, and it will reflect direct blood which will be inserted in the blood. Okay, and but if we are talking about the sensor, of course we have a small one, broad, very small broad, will be inserted under the skin, and it will just transmit the blood sugars which will be in the interstitial space. So we have electrical signal generated from oxidations of glucose, which was being recorded by this sensor. So the signal are calibrated with meter reading to calculate a CGM value. So we are just talking about different side of blood glucose, either to be directly from the capillary when we're using the old meters, or the blood glucose monitoring one. And there is another parameters which, if you take it from the sensors, or continuous glucose or a glucose sensor, which is you need to take the interstitial space. Bear in mind there is lag in time between this direct record for the blood glucose to record which will be secreted from the interstitial space, which may lead 5 to 10 minutes travel times. So every time put in your mind this information, and as we will discuss it later in more details. Okay, so CGM continuously measures the blood glucose, can give you reading every 1 to 5 minutes, up to 288 minutes per day over 24 hours. But if we talk about self-glucose monitoring, so the diabetic patient should be encouraged to prick himself. So sometimes we tell them the best time to be is pre-meals and during bedtimes, prior to exercise, and whenever he feels that his blood sugar suspected to be low, if he have symptoms, or if he have just another time, we just emphasize them to do it after corrections the low readings, because the low readings will not be accurate when we are talking about the subcutaneous blood glucose or interstitial blood fluid glucose. Okay, and again we just inform them we need to prick whenever prior to and while performing critical tasks like driving, swimming for a long time. So still the self-glucose monitoring is a cornerstone for a lot of scenarios. And the feature of continuous glucose monitoring, as we said, continuous glucose monitoring use tiny sensor inserted in the interstitial fluid, and a reusable transmitter send information. This is a transmitter. It will send information about the glucose level by Bluetooth from this sensor to a wireless device. Wireless device can be mobile phone, smartphone, receiver, or even insulin pump. Okay, so it is very nice that he will just check the blood sugars. And we said it is not only reducing or eliminated finger sticks, which is very, in some age population or some diabetic patients, small age groups, it is a very valid issue, but also we need the other characteristic shown in this CGM data, like the screen and trend graphs, rate of change arose, certain device even approved for dosing from remote monitoring, and a lot of multiple alarm systems. So the scenario is far beyond reducing or eliminating finger pricking. Here we have just simple illustrations about how it acts or what is could be the difference. These are patients who have been asked him to prick himself in the morning, pre-breakfast, pre-lunch, maybe pre-dinners, and he just is a pre-breakfast, and he did one prick test in the midday in the 7 p.m. in the evening. So if you see the trend or overall of if you see his blood sugars parameters, you said, oh, it's very excellent one. No need to change everything is fine. No need to change his insulin regimens because he have only one reading of high. As we all know, when we are measuring diabetes, we are talking about the trend. So we will not change things with one value. If it is, they have a reason for that. As he drinks something without giving insulin or whatever. So every time we need to treat or change our regimen according to the trend. And this is the same person. If we connect him to the CGM, every 1 to 5 minute records, we can see the graph now difference. We can see now there is something under the line we couldn't see in the regular monitoring. There is hypoglycemia, which is very critical because it is appeared between 3 to 5 a.m. That means during sleep time. There is hyperglycemia, which was being late after getting the evening. Here there is hyperglycemia. So a lot of hidden issue. We have seen it when we just convert the patients from regular pricking to the CGM data. And again, as we mentioned, the quality of glycemic report was being changed a lot. We admire our diabetes logbook, which we were given to the patients to check their blood sugar. We ask them simply to check the blood sugar pre-meals, that means pre-breakfast, pre-lunch, pre-dinners, and during sleep time. And this is how they write it, the readings. And again, this patient sent for me the records of the blood glucose. She did it at home. She write for me the blood sugars, the food she eat, either pizza, yogurt, and what happened after 2 hours. I think this is the best one to say to be helpful in the diabetes educator because we call it food diary because she may adjust the carb countings and see how she will act. So this is most beneficial for the diabetic dietitians. And another patient, I just follow her with my consultants during virtual clinic in COVID times. I ask her, yeah, I will just, you have very high A1C, but I want to adjust your therapy. So I will connect it to CGM machines. But before that, I need to see your record. I need to see how you are doing during that times using MDI. So she is nicely write for me a full data, writing her readings pre-meal, post-meal every times and during sleep times. And she knows she tried all the dishes. Okay, so I feel very shy because she just make a good commitment to me. But sometimes she's a teenager, sometimes you just questioning not only the handwriting, which will be difficult, not only the difficulty she take it while she recording, but sometimes she may have a mistake writing numbers. And if you just overcome the adolescent behavior that she may just write for you a number which does not exist. So I thank her for doing this best job, and I follow her in the clinic as I will show you later on. And if you are lucky, you have one-touch machines for self-glucose monitoring. So the dietitians will download for you all the reading the patients take it. So you will just overcome the mistakes or if she didn't check the blood sugar probe at that time or no, she fake it. So she will download for you from the machine the blood sugar measurement. It looks more organized, and you see the normal reading will come to you in a dark color, the high reading will come to you in a red color, and the high will come to you in a blue color. So to some extent you can see the numbers accurately. And just we are transferring our patients for this record to a new record, which is computerizing one, talking about CGM. You can see many papers in this CGM downloaded reports machines, but even from the first paper, you will see computerized data, well calculated in a percentage, in a numbers, in a graphs for summations, graph for daily betters. These numbers can be of great value while you are discussing the control of your diabetes. This is a report of the freestyle library. To some extent, this is the dashboard of the Dexcom, which to some extent looks similar, the same graphs, the same number, but it can be arranged in a different way, the same daily better. And we have even more sophisticated one. If we are talking of more simple than this, we are talking about in pen. Still, we didn't see it in our practice, but still, from the pen, you can transfer the data to the logbook. The logbook will be as a software inserted in your mobile. And again, data, numbers, everything, and you can even be giving the dose. So it will be for giving the dose, this pen, and for transferring data Bluetooth for the same times. So very clearly for you, the data was being different. Very different data from this data to the one which is computerized. And if we want to talk about the part of continuous glucose monitoring, as we said, there is a sensor with a small electrode inserted under the skin, and the transmitters will be on top of it. This is for the freestyle library, for the Dexcom, and you have a receiver to receive this data through Bluetooth, either through the Dexcom, either through meters machines, or through the pump, or again, you can have an app in your mobile to receive this data. So 3 parts to work together. Type of continuous glucose monitoring. Overall, they divided into 3 types: intermittent, real times, and professional CGM. If we have talked about intermittent CGM, it is known as flash glucose monitoring. This is like about freestyle library, which is commonly used nowadays. So the patients need to manually scan the sensor, okay? And the reader will store the results, and it can, we don't have a transmitter, but it can be transferred to these machines or to your app. Okay, and we don't need calibrations for freestyle library. This is intermittent scan one. The example of real-time CGM can be Dexcom or Medtronic. Again, it had transmitter attached to the sensor to continue sending the glucose readers, but it have just device on top of it, so it will just make it as a continuous glucose monitoring. Okay, so the receiver, this receiver attached to the sensor, it will reach a smartphone, or it can work with tandem insulin pump. Okay, or even if it is Medtronic, it will send to Medtronic insulin pump. Okay, receiver and app can be programmed to alarm glucose level, which is needed, and sometimes it needs a finger prick testing to do calibrations, will be twice daily. So it is not only a sensor which you need to scan it, it's the sensor and a transmitter attached to it. Okay, so no need to scan, the reader will go automatically by Bluetooth device to your receiver one. Okay, sensor is a transmitter. So if we are talking about the third type, which is professional CGM, it will be currently initiated in the clinic. You will do your electrodes, and then after that can be later analyzed after 10 to 14 days by clinic personnel, physicians one. It can be blinded or unblinded. Blinded, that means the patients cannot see whatever the reading was, or blinded, which he can access to that. I haven't seen it in the diabetic patients, but I've seen it in my practice in the patients with hyperinsulinism who develop hyperglycemia on oral medications, and we are just want to convince him that he need to, or want to convince that he have hypoglycemia, he need to do other modalities of treatment, which is partial pancreatectomy. So we insert him for 10 days and we see the hypoglycemia trends. So as I said, there is different types of machines, as I show you in the picture, the freestyle, Dexcom, the inlet one, and Eversense. And there is so many graphs talking about how different it was. And there is major things of difference, like a sensor life. As in Freestyle Libre, they have 14 days. The sensor can be used for 14 days. Dexcom 7 to 10 days. And Eversense, which I tell you, it will be implanted under the skin, it will reach for 6 months durations. Okay, number of calibrations for Freestyle Libre, you don't need to have a finger prick to just make the reading accurate, but in Dexcom you have, and Eversense you have, and all of them, they have trained arrows, they have alarms, and for Freestyle Libre, you don't have transmitter for the Dexcom. They have transmitter inlet. For Medtronic, they have Guardian Connect or Guardian 2 link or mini link. If you have Eversense, they have Eversense X link. This is a transmitter, as I said, which is be on top of the sensor, which will transfer the reading every 1 to 5 minutes. Okay, and again, it's the important things we need to know that all these sensors can be applied by the patient himself, except the Eversense can be imparted by healthcare specialist, as I said, which is small electrode under the skin. Okay, and all these machines can be differentiated by the MART. MART simply it will reflect the accuracy of the machines as a medium absolute relative difference. For all of them, 9, 9, 13.6, and here for Freestyle Libre, the new one is 9.2, with the old one 11.4. Again, you can go to the road from intermittently scanned glucose monitoring to hybrid closed loop system. Okay, key of success paper. And as I said, if we are talking about MART, we are talking about accuracy. It is the average of absolute difference between a reference measurement, which is laboratory standard, and CGM measurement. Whenever you have low MART value, indicate more accurate sensor. And overall, all the sensors, the new sensor is ranging from 8 to 14. And these many devices can allow physicians or user to make treatment decisions, and you don't need to do most of the time finger pick stick if the MART will be less than 10. So less than 10 is the cutoff value of most of them. And thank God we find it computerized, and numbers will be available with each machine. But this is the mathematics issue, how they will calculate the MART of that machine. And I will tell you another issue about, maybe we are talking about how there is a difference. Many patients come to you in the clinic, tell you we have great difference from the blood value to the CGM one. Okay, so this value exist, but it can be less than 20 to 40, not more than that most of the time. But there is difference. I will show you one. If you just observe this trend, this illustration for roller coaster, we will just assume that the blood is the first trolley, and the last one is a CGM. As we tell that the blood we take directly. The pricking will be directly from the blood, and here will be from the interstitial fluid, which is lag already we said there is lag from 5 to 10 minutes. So lagging, that means he will be at the end of roller coaster. So they said when glucose level is stable within normal limit, the sensor reading and blood glucose reading could be similar. To some extent, it could be the similar. This is why sometimes we, even for the accuracy of the sensors, we ask our patients, whenever they want to just insert a sensor, they need to be inserted in a normal value blood sugars. Okay, to insert accuracy. So what happens when the glucose level is trending up, especially if we are talking about trending up very quickly, very rapidly? So simply the roller coaster will go up very quickly, so the reading in the blood will be high, and still the reading from the sensors will be lagging behind because it still was being downward. Okay, this is happening when the patient is correct from hypoglycemia. If a patient's correct minor hypoglycemia, the blood sugar in the blood will be corrected quickly, but still if you just check in the sensor, you will find lag, the sensor is lag behind, it still is not corrected, which is not true. Okay, the same story with when the glucose level is trending down, especially trending down very quickly. This can be when you give a corrections. When you give a corrections, still the sensor is still the interstitial fluids was not corrected, still because it is lag behind, but the blood level will start to be normalized. So take care, and every time put in your mind this machine of Relicoster as a simplified machine to just understand the difference when it will be during going from high or going from down the hill. And if you don't have facilities, sometimes you need to select which patients he need to be in a CGM. Okay, and of course, most of the patients we needed to be there, but as I said, the patients is 2 years age of older can be, according to recommendations. It's difficult to be exerted in less than 2 years, according to many of the sensors manufacturer advice. And we need to insert it to currently treat patients treated with intensive insulin therapy, the one who have experienced frequent hypoglycemia unawareness, excessive glucose variability. So we want to see the trends here. We want for hypoglycemia needs alarm, and there is variations for intensive intensive activities you want to perform it. And the most important thing, the patients who had desire to improve glycemic control, you want to understand their behavior and willing to able or use this CGM and willing to learn, because it is a shared process between the physicians and the patients. The patient should interact with this graphs, with this trend arrow, he should add notes. So everything, it is something to be shared between the physicians. And so it needs activations. It is not only, you need to tell the patient, it's not only a finger prick issue. It is more than that, more care. So a lot of data, a lot of reports was been talking about how CGM is effective. This one, mark improvement in hemoglobin A1C following comments of flash glucose monitoring in people in type 1, reduction in DKA and severe hypoglycemia in pediatric type 1 during the first year of continuous glucose monitoring, multi-sensor analysis of 3,553 subjects, and another paper, flash glucose flash continuous glucose monitoring to improve adherence to self-monitoring of blood glucose and self-efficacy in adolescents with type 1, effective continuous glucose monitoring on metric of glycemic control in diabetes, systemic review with meta-analysis of randomized control trial, and effective glucose monitoring on glycemic control, hypoglycemia, diabetes-related distress, resources utilized in the Association of British Clinical Diabetologists, and here the flash continuous glucose monitoring summary review of recent real-world evidence. You can go over all these data to see how they are convincing that this is a good best management for the patients. But here is finishing part 1. I will proceed to part 2, standardization of CGM data presentations, the ambulatory glucose profile, history, time in range, hemoglobin A1C and time in range, glucose management indicator, glycemic variability, optimizing the sample as a 14 days record, and AGV report standardizations. So I will go through, because this is the parameters they do it in the reports, the glycemic variability CGM. I will tell you what does it mean and how they create it and what is the clinical significance of that. Talking about standardization of CGM metrics and reports, it is a journey. It is a big journey started in 2002. In 2002, by a group of expertise, they meet together. Dr. Richards and his colleagues, they joining an expert panel of diabetes and specialists, and it was being held in Florida. They introduced us the first universal software report for HB, okay, and asked the provider to give them feedback feedback, and it is content, functionalities, both in the research and clinical trials. So they put the cornerstone for this CGM, followed by 2012, first approval of standardized CGM report, the AGB, again, the same committee met. And in 2013 to 2017, they came with international consensus of use of continuous glucose method. Again, the same group of diabetologists, specialists in it, and they just publish it. And here, international consensus of CGM, TGM, TR, time in range targets. It give us reports in clinical targets for continuous glucose monitoring data, and all of these, it was being in the magazine of advanced technology and treatment of diabetes. They did a good congress. And lastly, in 2020, ADA includes CGM at standards of diabetes care, which is include 10 core metrics and time in range target. So in my talks, I will discuss about these 10 core metrics, what does it mean, and how efficacy, and how it will reflect on our good control. Okay, as I said, this is the first paper, start to report, and this they try to first refine or doing the targets, which is best of the patients. They give us a target, the good results that they name it in range, that the patient should have reading between 70 and 180, and give us the color bar, which was being firstly used. The in range, the best target they needed, they put it in a green, and then they put above it employed 3 categories. Either high readings, very high, or dangerously high, and downward they said low, very low, dangerously low. Okay, and of course, if you are going to the trend upper, you have increase of DKA, and if you go down, you have great risk of hypoglycemia, until they name it as dangerously low level, which need urgent interventions. Patient can present comatose or renal convulsions also. So this is the first bar they make it. And you see here, they make it as a 7 category for blood glucose readings. And again, in the same times, they just discussing the limitation of hemoglobin A1C. We know all of us that hemoglobin A1C, just question, is it the standard? Yes, for many years, we just said it's a gold standard for management diabetes because easy to measure, relatively cheap. It will give, there is many data, many data talking about the predictive of vascular complications, cardiac one, renal ones, especially in adults groups. And it is often used to guide management decisions. Okay, but the limitations we all know, it will need 3 months durations to have decisions, and we all know the problem of some disease like hemoglobinopathies, renal, liver disease, iron deficiency will be interact. But again, we are talking about new things. That hemoglobin A1C is a poor indicator for hypoglycemia and glucose variability. And again, it differs from one patient to other because there is different in glycosylations, lifespan of the RBCs. So we are just questioning hemoglobin A1C. So we did not throw it, but we said they just discussed that there is a need for metric beyond hemoglobin A1C to address all these limitations which we have in hemoglobin A1C. Okay, again, as I said, then they later on refined their work, this diabetes specialist in 2017, and just they shrunk the time in range threshold from 7 categories to 5 categories, which was being exerted now. So they said the first category is the green one, is time in range, and then above it, they exerted into 2 levels, level 1 and level 2, or you can name it high or very high. And the hypoglycemia, again, 2 levels, level 1, which need attention, and level 2, which need immediate action that the patients will be critically ill. So they shrunk the data to 5 thresholds, and you can ask yourself why they make this solution, especially for hypoglycemia. At that time, they put a great concern of the hypoglycemia, because all of us know that hypoglycemia in type 1 is more worrying thing than hyperglycemia most of the time. So the degree of hypoglycemia that cause clinical symptoms, they try to cut off value, which you can, which that counter-regulatory response is specific to individual and depend, it varies from one patient to other. However, they try to put a cutoff value of if the reading less than 54 milligram per deciliter. 54 milligram per deciliters. Why? Because they take it for, especially if it is continued for more than 120 minutes. Okay, because it was being discussed as this is a prolonged hypoglycemia, and they found in one research written study by us, and that the glucagon signal decreased with the rate of about 10% per hour in the human brain at a blood glucose of level of less than 54, indicating a mobilization rate commensurate with the severity of hypoglycemia. So from this research, they give us the cutoff value of less than 54 milligram per deciliters to make it as a severe level, very low level, or level 2. Okay, that means that your auto response, which can be exerted normally in your body, will not be if you reach this level. Okay, so every number they make it on a purpose. Okay, type visualizations, analysis, and documented of key CGM metrics. So they finalize the shapes. Firstly, before finalizing the example for 2016, they write here the names, and they write in the middle our 5 metrics which we talk about. But they give us another data, very condensed data about hyperglycemia, hypoglycemia, how it will take, which time. They try to calculate it, the hypoglycemia more. Again, the report to some extent was very condensed. And as I said, the major concentration at that time was in hypoglycemia. Okay, so moving to that contents ratio, let us discuss the paper which was being published in 2019 about clinical target of continuous glucose monitoring data interpretations and the recommendation from time in range. So simply what we mean by time in range. The bar which I discussed before with you, time range is the time spent in an individual target glucose. Target glucose, they advocate the range to be between 70 and 180. That means 3.9 to 10 millimole. And it acts as a metric value of glycemic management, provided more actionable information that hemoglobin A1C alone can be. So again, advanced technology and treatment of diabetes expert panel agree that establishing target percentage of time in the various glycemic range with ability to adjust a percentage cutoff point to address specific needs of our people living with diabetes. That means you have this range fixed for some group, but however, you can make another range for another different groups. Okay, for example, and even it will help you in making your efficacy and treatment. So here we came the first, the 5 metrics which we call it, as I said, time and range, we call it between 70 and 80, and level 1, level 2, as I said, hyperglycemia, level 1 and level 2. If you want to say, if you are talking in research, you know that you need to talk in levels, but if you are talking with the patients, you can say high, very high, low, very low, and the cutoff value we set between being a low, it is from 69 to 54, and very low, less than 54, as we mentioned, because the autoregulations of glucose signal will be less by 10% if it's continuing for more than 2 hours. So, and here the high 180 to 150, level 1, and very high more than 150. So this is the basic, beside the other parameters, which we will discuss it in detail, what does it mean, GMI or glucose variability, and the timing period. Okay. CGM-based target for different diabetes populations. As I said, they said CGM metrics individual care can be changed from different age groups. For example, we said this is for type 1 diabetes. 70 is the green bar. So most of the time I tell my patients I need the green issue all of our lives. So the greens, if you go to the level 1 or high, you can go with this yellow. If you go to level 2 very high, you can go with orange one, and the red. The amber red will be low, and this is the very low, the dark one. Okay, but if you are talking about old age groups, high risk group, that means high risk of hypoglycemia. That means you need to change their care. You need to change the care from being hypoglycemia to allow serious shot of hyperglycemia for them, because we don't need any hypoglycemia anymore because they have our awareness or they are dementia also. So they become more flexible with this group. But the reverse of the story, when we are talking about pregnancy or gestation and diabetes, all of us, we know that the side effect of uncontrolled diabetes on the fetus life or on the mom during pregnancy. This is why we are very strict to how they said to have these green bars, the time targeting range, they read it very high records. And they did not allow the reading to be of high. They give her only one level. They don't allow her to have reading more than 140 most of the time. Very limited reading and very limited readings for the hypoglycemia. So this is restrict control for pregnancy. Overall, you can put your target for one patient. If you said no, he's an adolescent, I don't want him the target to be between 70 and 80. I can set my values in my machine to 70 to 140. Whatever you set the value you want it can be. But again, the machine automatically, when it exerts the bar, when it calculates the first data, it will be calculated as a target between 70 to 180. So your target, you make it can be appear in the graphs, in the daily patterns. But again, all the machine was being full calculated to be between 70 and 80 for these numbers. Okay. So as I said, this is the final number I reached for my patients with type 1. Every time I tell them I need the green bars. And you can select a language which you will talk during your clinic with the patient. Sometimes if small age groups, I can talk in the colors. If you are more sophisticated in a teen or in school age groups, you can talk in a percentage. I tell him now you have percentage of 60. Let us make it next clinic 65. This is your score. The school age group, they know the score and percentage. And if you are talking about parents, sometimes you need to tell him he is more in hours time. That I need all the reading to be 16 for the last 16 hours per day, 45 minutes to be around 70. So if you count the sleeping time with it, so it would be most of the time he's under control. So take whatever you love to talk with the patients, select the language which you use it, either colors, percentage, or numbers in hours per day to address and to share it with your patients, because you need to reach a target. The targets cannot be reached unless you discuss it with your patients. Okay, so relations between estimated A1C and time in range. As we know that time in range, as we said, the best one was being between 70 to 180, which is 70% of the reading should be there. And they did they just convinced us by comparing two papers. One paper did by PIC. They take 545 participants with type 1. Another very big papers, or it will take large numbers, 1,137 participants in type 1 and type 2, done by Vintirisky. And they correlate each other. For the first age group, small age group, they find if they have 70% percentage time rate between 70 to 180, the hemoglobin A1C will be around 7% in the lab. Okay, the other age group, they said the other big data, she said if you need this 70% time range, the hemoglobin A1C will be around 6-7 in the round. So this is why they advocate a 70% as a number for acceptable time in range, as the ideal time in range for the patients. And for the data, as I said, the number is slightly different. Here, every 10% increase in time in range will give you around 0.5% A1C reduction. Here, about 0.8% reduction in A1C. So simply, we talk to the patients, tell him, if you increase the time in range from 60 to 50, your A1C may change by the whole one number, if you want to sum it to some extent. And this is how you will discuss it by 0.8. Okay, even very few details reached from these reports or this is research, that every 5% it will be increase in time in range. It's associated with clinically significant, and even the 5% you tell them. Only 5% you have clinical significance. Okay, the 5%, it means less than 1 hour per day. If you just control yourself in this 1 hour per day, it will give you clinical significance in your body and controlling diabetes. Furthermore, from the paper of validation of time in range as outcome of measure for diabetes clinical trial done in 2019, they said each 10% decrease in time in range, the risk of retinopathy and microalbuminuria will be increased. That means by 10% decrease, it will give us 64% increased risk of retinopathy and 40% increased risk of microalbuminuria. So it is reverse, opposite things. Okay, so you need to improve the time of range to decrease this risk. So now we have a paper comparing. Not like before. Before, all the paper talking about hemoglobin A1C and retinopathy, hemoglobin A1C and cardiac, hemoglobin A1C and chronic complications, renal. Now we start to have a paper talking about correlations between time and range and these complications. Okay, so talking about what they mean by the other parameter, what they mean by glucose management indicators, which was being included beyond the 10 metrics. One. Okay, glucose GMI, it cannot replace hemoglobin A1C. First time when they named it, they said estimated A1C. So it will reflect as if it was been A1C. Then they said estimated, no, it will just mix the idea of hemoglobin A1C, which was being done in the lab. It is a different scenario. So they named it glucose control indicator. Then they said, no, control is not a good word. If you said someone control you, it is not nice word. So they use glucose management indicator. Okay, and so the glucose management indicator, it look like an estimated A1C, and it will tell us this is how they make it as a calculations. They took it from the mean glucose, which can be integrated in this data, and so you should not mix it with hemoglobin A1C. And again, they give us a graph. As I told you before, there is a graph we all know. We saw it many times in our life, talking about hemoglobin A1C and the blood glucose, mean blood glucose. So they tell you, for example, if you have hemoglobin A1C of 9, that means your blood glucose will be around 300. And the patients and the families, they used to see this graph every clinic when they came after 3 months to correlate hemoglobin A1C with blood sugars. Now we have a new graphs for CGM drive mean glucose, and we call it not hemoglobin A1C, glucose management indicator. So we tell him, if you see this percentage, if you see your glucose management indicator around 7.5%, that means your mean glucose value is around 175. So now we have new record to show the patients, to convince the patients, to transfer the patients from the old hemoglobin A1C scenario. So do we need to get rid of hemoglobin A1C? No. Still, hemoglobin A1C is the gold standard, but as we know the limitations and the advantage, and we know that we need to wait 3 months for it. But this is a quick value. We can see it every 2 weeks. We can give a clue what to do and how to improve our management and take care. Okay, so again, Of course, we are talking about difference with glucose management indicator and laboratory hemoglobin A1C. And again, we have data in 2018 in this paper talking about how different they found it. They said 19% of the time the value is matched. This is what they said. Number of 528 participants, and 51 of the time absolute difference will be less than 0.3 or more than 0.3. Okay, and they said 28% of the patients absolute difference will be 2.5%. Okay, and more than 0.5%. So they just, if you calculate the 19% and 51%, which we said, yeah, it is a little different. So you'll find yourself talking about 70% of the patients. 70% of the patients, to some extent, you can accept the difference of hemoglobin A1C from glucose management indicator from hemoglobin A1C. So as in diabetes, we treat trends. We reach the major category, so we can take it as the first parameters to be quick parameters to just change our management plans or our care to diabetes till we reach hemoglobin A1C after 3 months, and we can compare at that time with each other. So it is a good parameters to be taken. Okay, of course, sometimes you have glucose management indicator, you find it higher than the laboratory. Maybe the patient has short period of acute hyperglycemia, had illness, steroid therapy, he wanted DKA, or the reverse of the story. If you find it lower than hemoglobin A1C, again, may have short period of hypoglycemia. Maybe he start physical activity, start new diabetes medication, so it can be lower than the one which will take the summation of the 3 months. So be flexible at any times and just observe what is there. So again, new data talking about glucose management indicator replace A1C in patients with CGM sensors, glucose management indicators, a new term of estimated A1C from continuous glucose management diabetes. So many papers started talking about. Another parameters I need to discuss glycemic variabilities and clinical implications. What do you mean by glycemic variability, which is one of the 10 metrics measurement? Glucose simply it is swinging of blood glucose level inter-day. So it will give us inter-day glycemic excursions, including episode of hyper and hyperglycemia. So up and down graphs. Okay, diminish or absent. What will make this up or down graphs to the patients? It diminish or absent. It may be due to diminish or absent glycemic autoregulations or short part of insulin variability are hypothesis to be etiology factor for this glycemic bump. But whenever we have it, it should be less than 36% to not affect your body. Should be calculated as an ideal less than 36%. And this is how all these holographic shapes, this is tell you how they will just count it. How they can make it standard. Someone will be in the standards in the machine will find it as a number. But this is how the tools they use it to make it. And sometimes you may one of your patients come to you and tell you, yeah, I have hyperglycemia, and then I correct it. So no problems. Now it was being corrected. No, you should tell him whatever you correct the hyperglycemia or hypoglycemia, these extortions or this is up and low will make damage, especially you can show him this very complicated pictures for the minute oxidative defect of pathological mechanism of hyperglycemia induced cellular damage mediated by oxidative stress. So you will just damage your intracellular process by this all oxidative tissue. So simply you tell him you just correct it, now it's okay, but it will harm your body. I think harming body is more than enough word to discuss with the patient. Okay, and here, as I said, the effect of glycemic variability, it will make this swinging of the mood, depression, and anxieties, and it will make more problems. Will impact on IQ. Okay, so simply you tell your patients that this glycemic variability will be responsible about your intelligence, your school performance, your stress management, and will affect you badly. And there is a lot of paper talking about fasting glucose variability in young adults, which affects their cognitive effects. Even this is mainly adult types, and even they said even in non-diabetic patients, swinging of blood glucose, greater variability was associated with worse cognitive process, attention, and memory, even in midlife. So the swinging is not acceptable at all. And as we said monitoring CGM, it is more than one target, more than one care. We know that hemoglobin A1C is still there, but time and range will make it both of them new standard of care together. And they said this example of real patients who have hemoglobin A1C 6.7, which is excellent. But if they talk about variability, you see how here his reading is up and downs, which cannot be seen in hemoglobin, reflecting hemoglobin A1C, how time of hypo he get it, these patients, and how time in range for each. This is only time in range is 5.1. A1C is okay. So if you see A1C alone, it will give you different value. It will give you different historical value than to see all these parameters together, to put all these parameters together in a patient's care. And last thing, why they said that it is sample needed 14 days, because again, they related to the research done as optimal sample duration for continuous glucose monitoring to determine long-term glycemic control. They said the 14 days, I don't know too much about statistics, but they said 14 days old, it will give you simple data which can be exerted like a 3 months value, especially if you are talking about mean glucose, the mean glucose, and time in range, and hyperglycemia metrics. So this is a very valid data you can exert it. If you take 14 days, it will be similar to 3 months. So the advocate, the best time to analyze your patients will be a 14 days duration. And lastly, as I said, we reached in 2020 a standardized of medical care of diabetes by ADA, and just write it as a 10 metrics as we discussed. So we discussed number of days, why to be 10 to 14 days, and they need percentage of time CGM active to be minimal 17% of the data. So you need to scan if you are a scanner, or you need to attach it goodly. Mean glucose is the mean glucose value. Glucose management indicator, we discussed it, it's similar to hemoglobin A1C, and gelatin variability, which needed less than 36, and we know about the accuracy and importance of it, and the 5 important category which they make it, either time in range, above range, and which is level 1 and level 2, and hypoglycemia level 1, level 2, and the cutoff value standardized for each patient. Whenever you have patient in CGM, all these robots, they will give it in a normal, and they will give you the data which you have it, and this is how it will appear. Okay, number of data, how active it was, and every time they give you a box of a normal readings which you want to exert it, so it will be near to the screen you have it. So simply you can go tell him this is the best, and this is what you have, and this is the value, and how we write an average glucose, mean glucose management indicator, and variability. And this is the bar, nice bar which I tell you about. As a realtor, you can using the colors, the numbers, or percentage, or the hours time. This is the 10 metrics which we reach it as final. By this, I complete my second part. My first part of the lectures, I hope it is clear. This is the Sudanese top, the white one, which will be wear by the teachers and old women. It's a very nice one. Thank you for attending my lectures, and inshallah next time we will process to the second part of my readings. I hope it will be beneficial. Thank you.